That awful scratchy feeling right at the back of your throat, you know the one, makes swallowing just miserable.
We've all been there, I think.
Definitely.
Yeah.
Sometimes it's just a cold, gone in a day or two. But what about when it's more focused? Right on those lumps back there.
Yeah, the tonsils.
Exactly.
Okay.
So this deep dive is for you. We're using some detailed revision notes all about tonsillitis. It's super common.
Right. And the plan is to unpack these notes together.
Pull out the really key stuff, the high-yield info you need, whether you're actually revising or, just curious.
We want to make it clear and memorable.
So we'll start with the basics. What is it? What causes it? Then move through how it looks, how it feels.
How it's diagnosed, managed, the whole picture, prognosis, complications, the works. We're covering all the sections laid out in these notes.
Okay, let's get into it. First up, the definition. What exactly is tonsillitis, according to the notes?
It's pretty straightforward. The notes define it simply as inflammation of the tonsils, those lymphoid tissues right at the back of your throat.
Simple enough.
Yeah.
But the notes make a point about distinguishing it from other things.
Yeah, and this is crucial early on. Tonsillitis means the tonsils are inflamed. Pharyngitis is broader. It's inflammation of the oropharynx, the back of the throat generally, which might include the tonsils but isn't limited to them.
Okay, so pharyngitis is more widespread back there.
Exactly. And laryngitis, that's lower down, voice box stuff, usually causes hoarseness. So yeah, not all sore throats are tonsillitis. That's a key takeaway right at the start.
Got it. So it's specific to the tonsils. The notes also say it's usually an infection, starts viral, but then bacteria jump in.
Right. About half the time, bacteria are the main cause, or at least involved. Initially, maybe viral, but then bacteria can take over, and the notes name a specific one.
Okay, so let's talk causes. Etiology, what kind of bugs are we looking at?
Well, lots of viruses can kick it off. Things like rhinovirus, the common cold virus, or influenza virus, they're often the first invaders.
But the bacteria.
The notes are really clear here. The most common bacterial cause, the one you really need to know, is Streptococcus pyogenes.
Also known as Group A Streptococcus, or GAS.
That's the one, Group A strep. Much less often you might see things like Haemophilus influenza or Streptococcus pneumonia, but GAS is the headline act for bacteria.
Knowing those names feels important, especially for treatment later on.
Absolutely. It really directs the management strategy.
Okay, so who's more likely to get this? Are there specific risk factors mentioned in the notes?
Yeah, there are a few things. Being in close contact with someone who already has it is obviously a big one. Makes sense.
Standard infection spread.
Right. Also, things like having a weaker immune system, being young, and even exposure to environmental irritants like smoke, maybe.
The notes get pretty specific on age, don't they?
They do. Age 5 to 15 years seems to be the peak time for getting tonsillitis.
Okay. Any other factors?
Immune deficiency is listed again. A family history, interesting that they even mention atopy, that tendency towards allergies like eczema or asthma, and just being in crowded places, enclosed spaces where germs spread easily. Think schools, nurseries.
Right. And for bacterial tonsillitis specifically, does it list separate risks?
It reinforces some of those. Close contact, again, poor hygiene makes it easier to pick up bugs, weakened immune systems, and those crowded settings like schools and daycare. Basically, anywhere people are packed in together. Proximity is key.
Makes sense. So how does it actually happen? The pathophysiology, how does the infection take hold?
The core idea described is pretty simple. A pathogen, virus, or bacteria gets in and triggers inflammation in the tonsil tissue.
How do they usually get in?
Typically through the respiratory system, breathing them in,
Right.
or direct contact, like touching something contaminated and touching your mouth or nose.
And for the bacterial kind, the notes specify.
Yeah, usually respiratory droplets. Coughs, sneezes, or touching contaminated surfaces and then, touching your face. Pretty standard ways infections spread.
Okay, now this leads to a really important bit in the notes, differential diagnosis. Because a sore throat isn't always tonsillitis. What else could it be?
This is a critical section. The list helps avoid misdiagnosis. What else presents like tonsillitis?
Right, let's go through them. The notes call out strep throat, which, okay, is bacterial tonsillitis, but they list it separately for clarity.
Yeah, makes sense. Also, infectious mononucleosis or monoglandular fever, and peritonsillar abscess, which is a collection of pus. That's to the tonsil.
And how do you tell them apart? The notes give clues.
They do. A regular viral sore throat, usually milder, often comes with other cold symptoms like a runny nose or cough. Tonsillitis, especially bacterial, often lacks the cough.
Okay, what about the others?
Coxsackie virus can cause specific things like hand, foot, and mouth disease. You might see blisters or sores in the mouth or throat, which is a visual clue. Mono, particularly in teenagers, can be dramatic. Really large, pus-covered tonsils, severe tiredness, maybe an enlarged spleen. Herpes simplex virus is another possible cause, mentioned for adolescents and young adults.
And strep throat itself, specific signs.
The notes mention swollen, coated tonsils, fever, and often really bad breath. But then there are the red flags, things you absolutely cannot miss.
Like?
Epiglottitis. Inflammation of the epiglottis, that flap covering the windpipe, that's a medical emergency. Needs immediate hospital admission.
Okay, that sounds serious. Anything else?
Unilateral tonsil enlargement, one tonsil much bigger than the other. The notes flag this as needing investigation for potential malignancy, like cancer. It's rare, but crucial not to miss.
Wow. Okay.
And they also mention less common infections, like gonococcal pharyngitis. Need specific tests.
And HIV was mentioned too.
Yes, particularly in children. It can present with ENT symptoms, swollen glands, oral thrush, ear infections, which might initially look a bit like tonsillitis or other common issues. So that differential list is vital. Think beyond the obvious.
Good point. Shifting gears slightly, epidemiology. Who gets this most? How common is it?
Well, as we said with risk factors, it's mainly children and young adults. The notes say exact UK prevalence figures are hard to pin down, but sore throats, including tonsillitis, cause a lot of GP visits and time off school or work. It's a significant burden.
There was a statistic in there about GPs.
It's quite striking. A GP with about 2,000 patients might expect to see something like 120 cases of sore throat a year.
That's a lot.
It is. But the notes also add, interestingly, that most people who get a sore throat probably don't even go to the doctor. They just manage it at home.
Right, so what we see clinically is likely just a fraction of the total cases.
Exactly. Tip of the iceberg.
So let's talk about what it actually looks and feels like. The clinical presentation, symptoms, and signs.
Okay, the classic symptoms listed are sore throat, obviously. Pain, when swallowing, the notes use the term odynophagia.
Odynophagia, got it.
And dysphagia, which is difficulty swallowing. Also, tender glands in the neck, fever, headache, and sometimes that classic yellow or white coating or patches on the tonsils.
What else might someone experience?
Earache is common, often referred pain from the throat. Just feeling generally unwell, run-down malaise, sometimes quite a high fever.
And what would a clinician look for on examination?
Enlarged, red tonsils are key. They might or might not have visible pus that exudate. Bad breath is often mentioned. And those swollen, tender neck glands, cervical lymphadenopathy.
Any other signs or symptoms the notes highlight?
Yes. Throat pain radiating to the ears is specifically mentioned. That's a common feature. Abdominal pain can occur, especially in children. And sometimes voice changes, maybe sounding muffled. On looking, it might just be a very red throat, or you might see those distinct white-yellow patches clearly on the tonsils. It's a collection of these things.
Okay, so you got the clinical picture. How do you confirm it's tonsillitis?
Yeah.
And crucially, is it bacterial? What about investigations?
The notes emphasize that diagnosis is often clinical, based on the symptoms and the examination findings.
But sometimes you need tests, especially for bacteria.
Right. If bacterial infection, particularly strep throat, is suspected, tests are considered. The notes mention throat swabs for culture, or, more commonly now, a rapid strep test.
Quick results with those.
Yeah, that's the idea. The notes also point out how to differentiate from glandular fever or mono using blood tests like a full blood count, FBC, looking at a blood film, and the monospot test.
And there was a point about urgent blood tests.
Yes, if there's any concern about an underlying immune deficiency, or if the patient is on certain drugs like chemotherapy or some specific medications, that can cause a granulocytosis, a dangerous drop in white blood cells. That needs checking urgently.
Now, this is where those scoring systems come in, right? Center and fever pain. The notes mention these as decision aids.
Exactly. These are super useful, high-yield tools. Center criteria are used to decide if a strep test is warranted.
Okay, what are the center criteria again?
As per the notes, point for history of fever over 38 Celsius, point for tonsillar exudate pus, point for no cough, and a point for tender anterior cervical lymph nodes. Score them up.
No cough is interesting. Why is that important?
Because cough usually points more towards a viral cause, like a common cold. Absence of cough makes bacterial infection more likely.
Got it. And fever pain, that's for antibiotics.
Yes. Fever pain helps guide whether to prescribe antibiotics. The points are fever over 38C in the last 24 hours, purulence, attended quickly within 3 days of onset. Severely inflamed tonsils, and again, no cough or coryza, runny nose cold symptoms.
So both systems flag no cough as pointing towards bacteria. Useful memory aid.
Definitely. Pus and no cough are key differentiators. The notes give guidance on the fever pain score, too.
How does this scoring work for prescribing?
For kids, a score of 3 or more suggests antibiotics. For adults, a score of 4 or 5 means consider antibiotics. For adults scoring 2 or 3, the notes suggest maybe a delayed prescription, give it a couple of days, see if it improves, unless they seem very unwell or are particularly vulnerable.
And rapid strep tests. When are they recommended?
In adults and kids over 3, if the center score suggests strep, is quite likely. For confirming bacteria, the notes list rapid antigen tests first line. If that's negative but you're still suspicious, a throat swab for culture. PCR is mentioned as an alternative, too. Understanding these criteria really helps rationalize the approach.
Okay, so we've assessed, maybe tested. What's the management plan? The notes break it down.
Right. Prescribing, non-prescribing, and surgical options.
Let's start with prescribing. Antibiotics if it looks bacterial, based on those criteria.
Yes. Or if the person seems systemically unwell, has a history of rheumatic fever, a rare but serious complication of strep, or is immunosuppressed. Those are specific indications mentioned.
Which antibiotics are typically used?
The notes name phenoxymethylpenicillin, or erythromycin if someone is allergic to penicillin, usually a 7 to 10 day course. And crucially, simple pain relief like paracetamol, and ensuring the patient drinks plenty of fluids. Supportive care is key.
And non-prescribing advice.
Simple stuff, really. Stay away from others if you're unwell, avoid work or school. For likely viral cases, reassurance that it usually gets better on its own within about a week. Interestingly, the notes say gargles are mostly anecdotal, not much solid evidence behind them, and watchful waiting is an option for kids with milder recurrent sore throats.
Then there's surgery, tonsillectomy. The notes seemed very specific about when that's considered for recurrent tonsillitis.
Extremely specific. It's not just for having it a few times. The criteria mentioned are for recurrent disabling tonsillitis. It has to significantly impact quality of life.
What are the numbers again?
7 or more episodes in 1 year, or 5 or more episodes per year for 2 consecutive years, or 3 or more episodes per year for 3 consecutive years, and those episodes need to be severe enough to be disabling.
That's quite a high bar.
It is. Other reasons listed for considering tonsillectomy include recurrent febrile convulsions triggered by tonsillitis, or if massively enlarged tonsils are causing obstructive sleep apnea, noisy breathing, stridor, or significant swallowing problems. Also, if a peritonsillar abscess doesn't resolve with drainage and antibiotics.
The notes mention surgery is effective.
Yes, especially for those meeting the severe recurrent criteria. Different surgical methods exist. Cold steel, diathermy, cublation are mentioned. And a really key point the notes make about antibiotics for confirmed group A strep tonsillitis.
Yes.
Their primary role, beyond just helping symptoms, is specifically to prevent acute rheumatic fever. That's the main driver for treating bacterial cases. For everything else, viral or bacterial, supportive pain relief, fluids, rest is fundamental.
Okay, so what's the usual outcome? Prognosis. Generally good.
Mostly yes. The notes sound quite positive. Most acute cases get better within about a week, assuming appropriate management.
Bacterial cases may be a bit faster with antibiotics.
Tend to be yes. And as we discussed, if it keeps coming back severely, that might trigger a referral to look into tonsillectomy.
Any other details on prognosis?
The notes reiterate that 1 week is the average duration. They mention that tonsillectomy in children who meet the criteria can lead to real improvements in health-related quality of life. And there was that interesting snippet about parental smoking cessation reducing kids' upper respiratory infections, including tonsillitis. A broader connection.
Right. But even with a generally good outlook, things can sometimes go wrong. Complications. This section seemed important.
Very important, because it highlights why getting the diagnosis and management right matters, especially distinguishing bacterial from viral.
So what are the potential problems listed?
Infection can spread nearby sinuses, middle ear, causing otitis media. A big one to watch for is that peritonsillar abscess or quinsy, that collection of pus beside the tonsil. Painful, needs draining.
And the really serious ones linked to strep.
Rheumatic fever, that's the major one mentioned, resulting from untreated group A strep, can damage the heart valves. And glomerulonephritis, kidney inflammation. Both are serious systemic complications. Rarely, very swollen tonsils can obstruct the airway, but that's uncommon.
The notes listed some others linked to group A strep too.
Yes. Besides rheumatic fever and glomerulonephritis, they mention Sydenham's chorea, which is a neurological issue that can follow rheumatic fever, and scarlet fever, that characteristic rash with strep throat.
Any other potential issues?
Strep infection can sometimes trigger or worsen a skin condition called guttate psoriasis, and just having chronically enlarged tonsils can disrupt sleep, particularly in children. The notes also list potential complications of tonsillectomy surgery itself, like bleeding, hemorrhage, ear infections, altered taste, and a historical, now very rare risk related to polio.
And the notes explicitly link poor management to these complications.
Absolutely. They state poor management increases the risk of things like peritonsillar abscess, deeper neck space infections, pneumonia, glomerulonephritis, and rheumatic fever. It really underscores the need for careful assessment and appropriate treatment, especially for suspected bacterial cases.
Okay, wow. So we've covered a lot of ground there unpacking these notes.
We really have. From the basic definition, the causes viral versus bacterial, especially group A strep, the risk factors, how it happens.
Through to what it looks and feels like, the differentials, what else it could be, how common it is.
And then the diagnosis, using those clinical criteria like center and fever pain, the tests.
Right, and management supportive care, antibiotics when needed, the strict criteria for tonsillectomy.
Finishing with the usual good prognosis, but also highlighting those important potential complications. We've hit all the key areas from the source material.
And having it laid out like this, drawn directly from these notes, hopefully gives you a really solid, structured understanding of tonsillitis.
It's about taking that information and making it stick. Turning the notes into, practical knowledge.
Hopefully this helps you understand this really common illness better and
Yeah.
maybe appreciate some of the clinical decisions involved.
And it leaves us with an interesting thought, doesn't it? The notes mention most sore throats don't even reach a doctor.
Yeah, yet they also stress the potential for serious issues like rheumatic fever from untreated strep.
Which raises that constant clinical dilemma. How do you balance providing timely access and treatment for the bacterial cases that truly need it against the sheer volume of self-limiting viral sore throats out there?
It's that blend of science and judgment, isn't it? Managing common symptoms while staying vigilant for the less common but serious possibilities. Definitely something to mull over.